Good afternoon. First of all, thank you so much for participating in our first ChicagoCHEC webinar. And we are really having a very important topic to discuss today, and that is about the importance of diversity in clinical trial. So some of the objective will be trying to define what is clinical trial and to really get into an in-depth discussion about what are some of the challenges and barriers to participation of diverse population, particularly people of color and other vulnerable groups in clinical research? And also to explore some of the myths that may prevail about the processes that people has to undertake if they decide to participate. So we're going to be having a very interesting discussion. And with that, we have a panel of experts that is going to be leading the discussion. To begin with, we have Dr. Caroline Waxon, who is currently the Chief Engagement Officer of the All of Us Research Program at the National Institute of Health. Corinne has been member of our family here in Chicago at the University of Illinois, having diverse positions there, from being a faculty to a researcher to having administrative role with the Miles Square Health Center. And he also was very much providing leadership at the local level regarding the Chicago All of Us program and the consortium that we have in the Chicago area. He has a master's degree and a PhD. And I forgot to mention that he also was affiliated with the University of Illinois Cancer Center, serving also in a leadership role there. He has a PhD in global health, specific in health sciences, and a Master of Science in Basic Medical Research, and a Master in Public Health, particularly in Community Health Sciences. And he has served in multiple federal grants from the National Cancer Institute and many other National Institute of Health grants. We also have with us Dr. Masija Jimbo, and he is currently a department head and professor of family and community medicine at the University of Illinois College of Medicine. And Dr. Limbo has a diversity of background. He has engaged in primary care practice in urban and rural community. He also completed a training in public health at the University of North Carolina, focusing on behavior intervention and research. He also is well funded through the National Institute of Health in a diversity of grants. So we do have a cadre of individuals that are really very suitable and have experiences in addressing issues that collaborate or are related to clinical research. My name is Aida Giacello. I'm a research professor at the Department of Preventive Medicine, Feinberg School of Medicine at Northwestern University. I will be primarily moderating the discussion and leading to some of the questions that we have for the panelists. So with that, what we hope to achieve today is not only the talk about the objective, make sure that we meet the objective, but also we would like to engage in different discussion about different topics that we have laid out, from what is clinical trial to what are the myths around, what are some of the barriers to overcome that. And then we want the last 10 or 15 minutes for the audience to be able to either raise questions about any other issue or elaborate further any issues or questions that they have. And we want, before we begin, to remind you that there's a post-evaluation survey. And so please, at the termination of the program, make sure that you fill out the survey, because that will give us some feedback about how well we were able to engage in this discussion and to what degree we were able to impact your knowledge and your attitude and behavior as it relates to clinical research. Thank you so much. And with that, no further ado, to Dr. Waxon and his presentation. Thank you. Thank you for being here.
Thank you, Dr. Giacello. So happy to be here. And I'll just briefly be before you all for the next 10 minutes to talk about the importance of diversity in clinical trials and the importance of transferring biomedical research through community engagement. Next slide. As Dr. Giaccella noted, my history is actually, I call this slide my why. When I first got interested in diversity in clinical trials, it actually started for me in undergrad and as an undergraduate student at the University of Michigan, because unfortunately I was presented with the impact of health disparities, cancer disparities at an early age. I lost my birth mother to complications from breast cancer when I was 7 years old, and learned then that we lived in an area that was, I don't like this term, but a medical desert. I lived in a small town that did not have access to an academic medical center. And I learned what an academic medical center was too early in life. I can't say that at 7, I knew that term, but I did know that where my mother got her treatment didn't necessarily have everything it needed to provide her evidence-based and quality care. Then later on later on in life, fast forward several years, I get a call while a sophomore at the University of Michigan that my dad had colon cancer. And once again, this concept of cancer had hit my family, at early ages. And this was after losing my maternal uncle, my dad's youngest brother, to prostate cancer before the age of 50. And so this concept of cancer disparities hit me early on in life. And I believe that my life and what I'm able to do has been the answer to my mother's prayers, although she wasn't able to live and see the advances that have happened, but there's been so many advances that have happened. So imagine my dismay several years later in 2010 when my oldest sister gets diagnosed with breast cancer. And knowing our family history, I remember talking to her and there was no conversation with her about family history. They had tested her, they had done genetic testing to see how they would treat her tumor, but they didn't talk to her about genetic counseling and family history and family risk factors. So that really was the pinnacle for me to really do a deeper dive into understanding how family history, race, ethnicity, diversity in clinical trials, how all these things inform the treatment that people get. And I then want to highlight how the role that UIC, the University of Illinois Chicago, Dr. Rob Wynn, Mr. Henry Taylor, and Miles Square, and others played in me really being able to actualize and operationalize my why, along with organizations like Project Brotherhood. So this first slide talks about the National Lung Cancer Screening Trial, the NCI, funded by the NCI. This was the NCI's largest study for lung cancer screening. And this was my introduction into the policy world. I learned through this study about the USPSTF, which is the United States Preventive Services Task Force. I know a big name, but I learned that there were screening guidelines that you would implement it that came from results of clinical trials, that a lot of smart doctors got together and they thought about these results from certain studies. And then this task force, which Dr. Melissa Simon is a part of, I want to give her a shout out. They come together and they make recommendations and give certain things a grade A through E or on what that recommendation should be. And when I looked at the amazing progress that the NLST, the National Lung Screening Trial on changing the landscape of lung cancer, I was so excited about this study. And I did a deeper dive only to find out that 4.4% of those 54,000 participants almost were African-American. Despite the fact that African-Americans carry the greatest burden of death due to lung cancer and morbidity and mortality complications, they were only 4.4% of participants. This was further complicated when I went to Miles Square and tried to help work with primary care physicians there to implement those guidelines for lung cancer screening. And what we found out was that those recommendations didn't match what we were seeing in our population. The minimum amount of cigarettes that they had to smoke in order to get screened, the age, we saw a very different demographic of lung cancer disparities in our population. So that led us to working with people like Mary Pasquinelli and Dr. Wynn and others to think about how can we utilize the UIC data to better inform screening guidelines. Second project that really was a part of my why, in addition to my family history, is work that I did with Mr. Marcus Murray and Project Brotherhood and Dr. Adam Murphy. Really understanding the burden of prostate cancer. There was some literature that came out that talked about the overscreening for prostate cancer. And it came out and it said that we don't know if we should be doing all the screening efforts that we're doing for prostate cancer. We don't know if an elevated PSA is saying what we really think it's saying. And this was concerning for me because this conversation was being had without the context of understanding the impact of prostate cancer in African-American men. This conversation was being had void of understanding work that had been led by Dr. Rick Kittles that talked about African ancestry, that said things like, if you are an African-American male and you have African ancestry of greater than 20% West African ancestry, you should be having a conversation with your doctor. This conversation was void of what we knew from the American Cancer Society about if you had a family history risk factor, you might need to get screened earlier and have a conversation with your primary care doctor. This conversation was also void of the fact that we don't have a lot of Dr. Murphys out there. We don't have a lot of African-American urologists where there's culturally concordance with the message, the messenger, and what we're trying to say. And so yet again, this concept of what happens when we're not included. And the last study I'll highlight is work that I saw also at Miles Square and amongst Latina breast cancer survivors that was led by Dr. Yamile Molina that started off in their career development, in their K award that turned into an RO21 and another award where they were looking at how can we empower Latinas to obtain guideline concording breast cancer screening guidelines, understanding that Latinas suffer disproportionately from late-stage breast cancer diagnosis, but the lack of inclusion of Latinas in breast cancer research had led to a lack of data in how we can do this in an equitable way. Next slide. So what does this mean in terms of diversity and precision medicine research? And now where I am with the All of Us research program. I have other countless examples of how, as a cancer prevention and control researcher trained in what's community-based participatory research, I kept seeing these examples. I remember, again, working in a community setting, trying to highlight and promote the use of the HPV vaccine for cervical cancer prevention, only to find out that when you look at the participants in studies that have been done to develop the HPV vaccine, yet again, those populations didn't represent the population that carried the greatest burden of disease. So what did we see when the HPV vaccine first came out? We saw a vaccine that covered 2 strains, meaning it was called bivalent. And those 2 strains that were originally covered, additional research shows that those strains did not cover other types, the strains that were more common in African-American and other minoritized women. And so that again let me know that there is this need for us to be at the table, for our data to be at the table as different screening modalities and interventions are developed. We see this also in the Asian American community because we aggregate data. We act as if Asian Americans are a monolith, meaning that they're all the same. So we hide certain disparities. You may, if you put all that data together and aggregate it, it may appear that Asian American women don't have elevated breast cancer risk. But then when you tease that data out, looking at Vietnamese women, for example, you may see in some areas of California that Vietnamese women may carry some of the similar burdens of breast cancer, mortality, and morbidity that you see in African American women in the Deep South. So it's really important for us to understand this concept of precision medicine. And I know we had 10 minutes, we started a little late, but I'm going to wrap this up in 1 minute, I promise. And also important to this concept called intersectionality. And what does that mean? And why is the All of Us research program important when it comes to intersectionality? That's understanding that we can't look at data in a vacuum. We can't just look at genetic data and say, oh, this is someone's genetics data. We can't just look at race and ethnicity, because remember that race is a social construct. That's a whole nother lecture. We also have to look at lived experience, what we eat, our access to healthy foods. So the All of Us research program is a historical longitudinal effort by the National Institute of Health to collect data from 1 million or more people where that data truly reflects the diversity of the populations in the US, and then to make that data accessible. Next slide, and I'll actually close on this slide, so we'll make sure we have time for questions. The pie graph on the right actually shows what other genomic precision medicine studies look like. That large blue circle there shows that the majority of genomic studies to date have been predominantly white and European descended, over 94%. What that means is that when we think about what genes will be accessible, what information we'll learn about genetics, we're taking that information from a very homogeneous population that doesn't reflect the diversity of the US, and therefore we're not sure if the findings will be generalizable to other populations. But look at what we've done in All of Us. Through intentional community engagement, we have now led to unprecedented diversity in precision medicine research. We are now the world's largest and most diverse genomic data set, with over 80% of our participants being underrepresented across multiple categories: race and ethnicity, living in rural areas, people living with a disability, population with lower SES, sexual and gender minoritized populations. And you even think about the fact that we have 16.8% African Americans enrolled, 16% Hispanic and Latinos enrolled. Where we still have more work to do, though, is in engaging more Asian Americans, and definitely more work when we think about our Middle Eastern, Native Hawaiian, Middle Eastern, Northern African, and especially work when we think about our American Indian, Alaska Native brothers and sisters and engaging them. And during the discussion, I'll talk a little bit more about the approach and how we got here. But I hope what I've done in this brief 10 minutes is frame for you why we have to have a seat at the table, not just as the participants, but also as the researchers asking and driving these questions. I want to thank ChicagoCHEC so much for giving me this opportunity, and I look forward to engaging in a discussion later on.
Wonderful. Thank you so much, Dr. Watson. And I just want to remind the audience, if you have any question, you could either begin some of the questions now, or you could very well write it in the chat. We do have a list of questions that we have prepared for this webinar, and we're going to start asking some of the questions to both of our panelists. And the first question is, can someone explain what is a clinical trial?
Sure. Try to make that as simple as possible. Clinical trial is to look at effectiveness of an intervention. An intervention can be a medication, drug, surgery, even what we call behavioral intervention, which is like some various communication tools. And we typically, what we do is a randomized controlled trial where we have one group undergo usual care without this intervention, and we call that a control group. And then the other group, which we call intervention group, which does, do get the intervention. And typically what happens is we try to do it in a way where, again, it's randomized so that who gets the intervention and who doesn't get intervention is completely due to chance, and also try to blind it as much as possible. What's meant by blinding is that a participant doesn't know whether they're getting that intervention or not. And we typically try to do that, particularly in the case of medication or drugs, with what's called a placebo, which is something that's very similar to the intervention, except that it doesn't actually contain the ingredient that's felt to be effective. And also, we try to do it what's called a double blind, which is not only do participants not know which one they're getting, but also the physician or the healthcare professional who's providing the care do not know whether the participant is getting the intervention or not meaning they get the placebo. And this is done so that we feel that if either the participant or the healthcare professional know which intervention or the placebo that they're getting, there may be some certain behavioral patterns that they may take that may actually affect the trial not in a good way.
Thank you very much. I know that Dr. Watson mentioned the low representation of people of color in clinical research. Why is it important to increase that representation? I know that you mentioned some of that, but is there other reason why we need to increase representation of community of color?
Yeah, thanks, Dr. Giacello. I'll start with that. One of the things that I often get at when I talk to communities, we saw a lot of this during the pandemic, right? A lot of communities said, well, I don't want to participate in clinical trials. I don't trust it. Rightfully so. There was a question in the chat about how do we work with marginalized communities and minoritized communities on, building trust. I actually think we should focus more on trustworthiness of the system becoming more trustworthy so that, and I'll get to that trust piece, but when you think about clinical trials, I start very basic. I tell family members, friends, communities, churches, wherever I'm given the opportunity, that when your doctor writes a prescription for you, if you have high blood pressure and you get that prescription written for a beta blocker or something that ends in OL or some drug out there, that drug has gone through a clinical trial. If that drug is FDA approved, it's gone through a clinical trial. If you have asthma, if you have diabetes, any condition you have and you get a prescription for that medication, it's gone through a clinical trial. So imagine that drug going through all the developmental stages and there not being people who look like you, who live where you live, who worship like you, who play like you, who eat the way you eat, involved in that. All those things come into play in us understanding the risk factors for those drugs in a very controlled environment. So I first like to start off with a reminder for everyone that all medications go through a clinical trial phase and start there, and then talk about the importance of us being engaged. Two concrete examples. Based on our ancestry and race and ethnicity, we may metabolize, break down drugs differently. Because there were not a lot of Asian Americans involved in clinical trials when looking at cholesterol-lowering drugs that often cause statins, we saw different side effects in this population and community when they were given statins and given these drugs to lower cholesterol. They had elevated side effects from that, and that's because they were under-engaged during the clinical trial phase. And the same example of what we saw with certain screening, when we think about colorectal cancer screening, if we didn't have various populations involved, there used to be a time when there's a thing called right-sided versus left-sided disease. I remember with my family history, I lost my brother from complications of colon cancer in May of 2021. And I remember talking to John Carruthers at the University of Michigan on a radio show right here at UIC, and the fact that I had what's called a sigmoidoscopy. And he texted me after that call and said, Kareem, with your family history, you need a complete colonoscopy. Even though at the time I was in my mid-30s, he said, you need a complete colonoscopy. What they gave you was not adequate. And it just blew my mind because I was like, I do this work. I'm in this field, and I didn't know that. So that's why it's so important for us to participate, to be at the table, to ask the right questions. I hope I've answered that question, Dr. Giancello.
Thank you.
Yeah.
You did. And I know that one of the questions that is in the chat is, how would someone learn about research study or in our area and how to get involved? I don't know if anyone may want to answer that. How do you know about research study? I guess they met clinical research or clinical trials, and where and how can they get involved? And then I know, Dr. Jimbo, you wanted to also add something in regards to the question about clinical trial.
Sure. Well, academic institution has a registry of clinical trials that's available through internet to various people interested in it. But I think, Kareem, you may actually have more information that's available federally, regarding these availabilities.
Thanks, Dr. Jimbo. Yeah, I just put in the chat a website called clinicaltrials.gov. Now, I do want to be upfront. I'll be the first to say I'm learning how to be a federal employee. I'm learning how to be a bureaucrat and to not be so critical of our things. I'm on this side now, but it's complicated. Even as a scientist, when I go through clinicaltrials.gov searching for trials, it's complicated, but it is a step. So I put the website in the chat, in the Q&A, hopefully others can see it, but it's clinicaltrials.gov. When you go to clinicaltrials.gov, it's sponsored by the National Library of Medicine. You can type in a disease condition. You can type in what state you live in. You can type in breast cancer. You can type in, studies that are actively enrolling, and it'll give you a list of studies in your geographic area that may be open and enrolling that talk about the condition that may be of importance to you. That's one way. There's also organizations that are popping up that I really like, that are local, that you can talk to. But oftentimes though, where you get your care makes the difference, because unfortunately most clinical trials happen in our large, big academic medical centers. So if you get your care at UIC, Northwestern, Rush, Loyola, University of Chicago, North, you name it, at one of the big, larger, what we call academic medical centers, they're probably going to be participating in some clinical trials. But if you get your care at a smaller hospital in a community area, that provider may not know about a clinical trial. So that's when you may want to reach out to organizations like the American Cancer Society, if we're talking about cancer, to see what clinical trials may be available to you.
Yeah.
Thank you.
Okay. Could I mention something?
Sure, please.
Thanks. I tend to call people by first name, but anyway, sorry, Dr. Watson. But so related to the clinical trials, pretty much all of the, I think, the federally funded projects that are clinical trials, the investigators are mandated to register into this clinicaltrials.gov. For example, I was engaged in a behavioral intervention, which is again considered a clinical trial, but I had to, make sure that our study was registered into the clinicaltrials.gov. So it is a very comprehensive list, and I think available state by state and also nationally. But I just wanted to mention a little bit about the importance of diversity in clinical trials. And one, of course, is related to within the biological context, where certain races and ethnicities may have more prone to get certain diseases or conditions because of their particular background. But also, I want to mention in the social context as well, how different race due to within the social context may have different outcomes. And I wanted to kind of mention this through one project that I did, which looked at what's called a decision aid. Decision aid is a tool that helps patients decide on a certain screening test or intervention when there's more than one option available. And then each of these two or more options, maybe they're equally effective, but the patient's preference might be different which option to choose based on their values. And what I did was I looked at colon cancer screening, and I looked at average risk people. And because for average risk people, colonoscopy every 10 years, or at the time that we did the study, a stool blood test every year was felt to be equally effective, and which one to choose, was based on what preference that the patient had. For example, do you want accuracy of all else? Then choose colonoscopy. Would you consider convenience to be more important, or would you rather have a more frequent test, where stool blood tests maybe more might be a better fit for you, particularly if it's hard for you to take time off work to undergo colonoscopy, or if the preparation is too much of a hassle for you. So what we did was we had about 15 primary care practices in southeastern Michigan, and we had these four research assistants fan out to all of these clinics to have patients actually undergo randomized to these decision aid tool before they actually saw their physician. And we wanted to see how this decision aid helped in their knowledge, and whether their what's called self-efficacy, which is they're thinking that they can get it done, and also intent, which is they're thinking that, okay, I want to get this done. And what we found out was, and then we oversampled Black and African Americans, because we wanted to look at some potential differences between African Americans and Caucasians. And what we actually found was that the baselines, that is, before we underwent this intervention, African Americans actually already had higher self-efficacy and higher intent to undergo colon cancer screening compared to the Caucasians. So they were already, motivated to get it done. And then when they underwent the intervention afterwards, we, did the survey again. Their intention and efficacy, self-efficacy, improved in the same degree based on the intervention. So what that means is African Americans started off having greater self-efficacy and also intention to get screened for colon cancer, and ended up after the intervention even with greater self-efficacy and intention to undergo colon cancer screening compared to the Caucasians. So once we checked to see whether they actually got screened after 6 months, you'd think that with the higher intention, higher self-efficacy, that the African Americans would end up being screened at a higher rate. But the opposite was true. After 6 months, it was statistically significant. African Americans were less likely to have undergone colon cancer screening compared to the Caucasians. And we wouldn't have found that out unless we had oversampled the African American group. This was about 600 patients altogether. And unfortunately, we can only speculate what happened in the 6 months that actually led to African Americans getting, colon cancer screening at a low rate, but we can certainly speculate that this is something not outside of within themselves, potentially the system. Was it the access, or was it the difficulty in getting the referral, or was it, the difficulty in undergoing colonoscopy? And, we do know that comparing the two groups, they had similar insurance. So, insurance wasn't an issue. And also they were similar, economically. So what, you can certainly say it's the racial inequity or racism, what's in the social infrastructure that may have led to it. But again, this, finding wouldn't have been, I don't think would have been available had we not oversampled African Americans.
Well, thank you for that example. There are a couple other questions that are in the chat. One of them is, why is it that clinical trial or medical research are not done more often regarding holistic and plant-based treatment instead of just being, pharmaceutical oriented? Any comments on that?
Sure, I'll start it, but a lot of it has to do with FDA and the way drug approval process goes, right? So there's, and being someone whose family is from the South, yes, I'll get a medical prescription, but I also will call my aunt and say, hey, I have this going on. What should I do? Because we know a lot of that comes from our culture and our heritage, and it works as well. But when you think about, for example, I had a family member that was, she was on certain blood thinners. But at the same time, she had got on this smoothie with a diet where she wanted to have a lot of smoothies, a lot of green smoothies. And I had to remind her that some of the food, the spinach, the kale, and the green things that she was putting in her smoothie, and then some other over-the-counter things that she was taking, could have a negative interaction with the blood thinners that she was on. So I simply told her, I said, the first place you should start is actually talk to your pharmacist. When you go to that Jewel Osco, that Walgreens, that CVS, and they say, ask the pharmacist, I encourage people to ask that pharmacist. Say, I'm on this medication, I have this diet. Should I be thinking about, what can I be thinking about this? But a lot of this starts with medical education too, and our public health education. We don't have a holistic track in medical education that really even teaches our medical students about how to understand how to integrate holistic, culturally derived therapies and other things into Western medicine. So there's so much with that. And so, and someone, I think the question asked, how is the All of Us research program working with this? We are now asking questions with like looking at environmental impact, but also our work through our tribal engagement, our American and Alaska Native research efforts are also striving us in this way to think about that. But a lot of this has to do with training. A lot of this has to do with the way drug development goes. Like if something is not going through a clinical trial process, it's going to be difficult for that provider to recommend it. And I don't even want to open up the can of worms about us living in a litigious society, meaning litigation. Oftentimes providers they don't have the luxury to say, try this, because if you try it, it hasn't been tested, it doesn't work. That could, open up to all types of legal issues that could potentially come up. So it's so complicated, but I do feel there's a way forward, but it's complicated.
And I also want to add that the National Institute of Health has a National Institute of Alternative Medicine that are doing a number of research. I'm not sure whether some of them are clinical trial, but are really looking into the effectiveness of a lot of the home remedies, particularly the minority and poor community tend to use during episode of illness. So that's another source of information that we should be able to find out their latest finding. Dr. Jimbo, do you want to say anything else on that?
Yeah, well, yes, related to that, I guess, they get less media coverage, I guess, than compared to, let's say, this new drug that works wonders on the Alzheimer's disease, for example. But you're right in that there are clinical trials that involve more holistic type of interventions, plant-based interventions, and others that are funded by the National Institutes of Health. But they may not get as much media coverage.
Thank you. And another question was about the fact that clinical trials are designed and included in those design inclusion and exclusion criteria. They purposely tend to exclude African American, brown, and other minority community, what can we do and be able to advocate for different kinds of effort to make sure that those clinical trials addressing other diversity of issues, health problem affecting people of color, are not really excluding them because of the tight way in which they design those trials?
It's please go ahead, Dr. Watson.
And please call me Kareem, Dr. Jim.
Okay, well, call me Moss.
This is
Yeah,
a
just call me
really good
Moss.
question. I was happy that Candace
Yeah.
Himley from Blue Hat Foundation asked this question. I remember early years when I was a clinical research coordinator. I was young and didn't know any better. I was at this is back when pharmaceutical companies used to have these study startup meetings where they would bring everybody across the country that was doing the clinical trial. They would bring you to one location and you would learn how to implement that protocol. Well, there was this one study that was looking at diabetes, to Candace's point, that had what's called inclusion-exclusion criteria. And at the time, so if a participant, had a blood pressure that was at the time, I think 140/85, they would have been excluded from the study. And I remember, again, I was young and didn't know any better. I remember asking the question, I was like, so y'all don't want Black and brown people in this study? Because everybody in my family has a blood pressure over 180/85. And they looked at me and I was like, no. I said, we're scientists. We can think about this. Why do you really need to exclude people with that blood pressure? And then they began to tell me, well, Kareem, it's because of the risk factors. If we have someone with this blood pressure in this study, this may put them at elevated risk. And then we're not testing the drug in a safe environment. I was like, we are all smart here. Let's think about other ways we could have designed that. We could have done multiple EKGs. We could have made sure that if you have a diagnosis of high blood pressure, you should be on a controlled blood pressure medication for at least 90 days before enrolling to the studies. And you see some of that now. But we also have to be, people who have this lived experience have to be the one designing the study, because we bring our whole selves to this. When I'm thinking about a study design, I'm thinking about my family. I'm thinking about access to healthy foods. I love the Mediterranean diet studies that are out there, but I'm also thinking about, will someone who lives on this side of the city have access to a grocery store where they can get those Mediterranean foods or that are in that part of that diet? But I think that way because of my lived experience and the exposure that I have. So we need a diversity of scientists developing these studies. But lastly, I want to talk policy. The FDA does have some guidelines out about that are now evaluating the inclusion and exclusion criteria. It's through the 21st Century Cures Act is requiring the NIH to examine barriers to including, for example, older adults in clinical trials and identify ways to design age-inclusive trials. So that's a step in the right direction, but I also would encourage you all to look at the FDA's guidance on this.
Yes, and one of the other questions is, and maybe this is maybe related to what Dr. Watson said at some point, that if you're getting care from a medical center, you're more likely to have access to some clinical research. So the question here is, how can you bring the clinical trial to the Black and brown community? What is being done? What are the ways that the researchers are trying to clear up the myth of the clinical trial in this community, which is a second question leading to that in the chat. So how can we bring clinical trial to the Black and brown communities?
Kareem, you might want to mention the citizen scientists actually here in terms of
I will,
engagement.
and I have a thank you slide at the end of my presentation. I know I didn't get through it, but I actually, before we log off, I actually want to, Angelique's going to pull up a thank you slide to thank some of the organizations that I've worked with, because when you're given these platforms, you have to understand how to use that platform to thank, the place you've been. And one organization I want to thank is Project Brotherhood, as well as Miles Square. When I think about the fact that Project Brotherhood helped come up with the curriculum and development for the citizen scientist work. It was Candace Himley with Blue Hat Foundation that actually helped me understand some of the policy issues that were happening around colorectal cancer screening. And it was Miles Square that was one of the first FQHCs that allowed me to develop a research engagement framework in Miles Square. So when you think about ways we can get more Black and brown communities engaged, the Murray model that was named after Mr. Marcus Murray and Dr. Linda Ray Murray. It's a published paper. I encourage you to Google it. If you are out there doing this work, you're a young scientist, you don't have to reinvent the wheel. There is a guide to help you do this work the right way with the right people. And the citizen scientist model talks about how you engage barbers in this work. You know, Project Brotherhood was engaging the barbershop community long before it was popular, long before people were publishing on it. And we made sure that when Project Brotherhood was a part of ChicagoCHEC, that we actually published a paper led by Mr. Marcus Murray talking about the Murray model and how they use just old school, but real scientifically proven ways to equitably engage communities. You know, Candace Henley and the Blue Fat Foundation is now international in going across the country and the world and talking about the engagement in clinical trials. And Mile Square, one of the few FQHCs where you can actually be a part of participating in a clinical trial at a fairly qualified health center. We need to make it easy, though, for our FQHCs to participate in clinical trials. They need to be compensated for their participation. They need to be, we need to make it not a barrier to care, but we need to make that a part of the work. So I just wanted to bring up this logo slide because this needs to be engaged in our mind that we don't do this work by ourselves, particularly for the young scientists that are on the call.
Yeah, I was going to add in one of the studies that I was leading with NCI funding that what we found was that physicians who are in storefront community setting are not invited to be part of the network of clinical trial. And the one way of accessing community of color and poor community is trying to talk and involve in those physicians that are usually ignored and sometimes are approached by the researcher only when they need to recruit participants. And so that's when they touch base with that physician that may be in a local community, but meanwhile, they usually are not included. So that could be another way, in addition to the barbershop and other community-based and faith-based community, we need to also reach out to those physicians that have access to our community or are seeing a large number of people of color. There's a couple more questions. One of them is, do patient-reported outcomes captured by providers and payer help influence the goal sample set when beginning clinical trial? I don't know if the person who wrote this wanted to be more clear about that. Her name or his name is Janice Barnell.
I don't know if I'm actually answering the question, but you know, for example, if a patient experiences something and the provider or the clinician that's taking care of the patient notices something that feels is kind of unusual or atypical, or feels like, okay, what's going on here? I need to figure out what's going on. And then they decide to study on it to see if there's this some new phenomenon or something that potentially novel. There are, before clinical trials, there are what we call like preliminary studies and feasibility studies, and bunch of, you know, before a project becomes a clinical trial, there are actually a whole lot of very smaller projects that are done to really try to define it, to define the goal of the clinical trial. And these, you know, phenomena that either the patient or the clinician experiences may actually initiate that whole series of these projects that may eventually lead to a clinical trial that can you know, change the parameters, or let's, you know, have tremendous novel findings. So I hope I answered that question, but
And Mashima, I actually want to just add to that briefly, Ida, if it's okay. Another way is through the institutional review boards, IRBs. So when something happens within a clinical trial, a negative finding, like if something bad happens, you have to report that. It's called an adverse event. You have to report that adverse event to your IRB, your institutional review board, because all clinical trials have to go through an approval process by an IRB, institutional review board. That IRB will collect that, and then depending on who the sponsor is of that study, if it's an industry study, meaning sponsored by a pharmaceutical company, they have to go through a way that they report it up. If it's a study that's sponsored by the NIH, we have to go through a way that we report that up. And depending on the severity of that adverse event, that can stop a clinical trial. I have seen clinical trials stop before because there were what we call adverse events, or specifically severe adverse events. And I want to shout out the development of IRBs because they came out of something we often don't talk about. Institution review boards, IRBs, actually came out of the unethical conduct of research that was done by the United States Public Health Service study of untreated syphilis in the African-American male. We inappropriately call that study the Tuskegee experiment. I'm going to ask us not to call that the Tuskegee experiment anymore moving forward. And unfortunately, we just published a paper with Dr. Sage Kim, and we mistakenly called the Tuskegee experiment in that paper, so I'm going to have to retract that somehow. But the reason I'm asking us not to call it Tuskegee experiment anymore is that I actually got a chance to go to Macon County and spend a lot of time in Macon County, Alabama, in Tuskegee, Alabama, and work with community groups. Even got a chance to meet Lily Head, one of the daughters of one of the last surviving members of that U.S. study of untreated syphilis in the African-American male. And what Ms. Head reminded us of was the importance of, she said something powerful to me. She said, Kareem, it's not that I don't want African-Americans to participate in clinical trials, but I want us to be informed. I want us to name what has happened. I want us to not forget history. And I want us to also make sure that we have the resources. So one of the things that we did, we partnered with Tuskegee University, a HBCU, Historically Black College University, and we left resources there in Alabama. One thing that Mr. Murray Marcus often talks about in Project Brotherhood is the unequal distribution of resources, particularly oftentimes minoritized researchers get less funding. As a result of us getting less funding, we work with minoritized organizations, they get less funding, and it's this trickle-down negative effect because of the research that we do and the lack of funding, which leads to more mistrust. But IRBs came out of the negative, unethical treatment that happened there, because that study went on from the late 30s to the mid 70s, and institutional review boards were developed to ensure that unethical research did not happen, including how we report adverse events and severe adverse events.
Yeah, thank you for that, because I know that in regards to Latino, we have the same problem that usually you are excluded because the investigator doesn't speak the language, in this case, Spanish, or sometimes that there is not resources allocated for translation of instrument or adaptation to some of the instrument assessment tools that are used. But now that you mentioned the IRB, can you, or anybody, or Dr. Jimbo, if you could discuss the importance of the consent form and what is that all about in clinical research?
Sure. You know, when the IRB came out, I think it was you know, based on 3 principles. I mean, beneficence, you know, first do no harm, that it doesn't harm the patient and brings benefit to the patient. Autonomy, which is the patient is fully informed and makes a fully informed decision to participate in treatment or testing. And 3, justice, which is more of a broader societal context in which the good of the whole group versus the good for the individual. But let me focus on the autonomy, because that was what was the important thing as far as the informed consent, is that a person undergoing clinical trial should be fully informed as to what it means to undergo this intervention, you know, including all the potential benefits and harms, and fully understanding what that means, and then have a full faculty, you know, make the fully informed decision to whether to undergo that or not. And another thing that's very important in informed consent is that even if you consent to the study, you can at any time decide not to participate. Just because you give a consent doesn't mean that you have to finish out the trial. The people who are the investigators who are doing the project, they cannot coerce you to remain in the study, and you can decide to leave the study without question. You know, you don't have to provide any. You can, of course, provide a reason for not continuing to participate in the study. But should you choose not to, that's perfectly within your rights. And just briefly about what Kareem has said about the how trials can be stopped. Pretty much all of the clinical trials have what's called a data safety monitoring board, which is not only comprised of the investigators who are doing the project, but more commonly by somebody external to the project that have nothing to do with what's going on in the project. And so they have like a more of a third person type of view, more objective view to see whether the safety for the patient is kept or not.
Thank you very much. I know that there's so much questions that we have and many coming up. And so we are now almost at the end, but there are a couple of other pending questions. One of the things that I wanted to ask that is in the list of questions that I have in front of me has to do with how do you really talk to your doctor about clinical trials? Do you just bring it up? Is it based on a medical problem you have, and you want to know if there's something else beyond what the doctor may be prescribing? How do we do that? How can we assist consumer to have a meaningful conversation on this topic? And how can the patient make a decision whether whatever the doctor is recommending is good for them, is the right thing that they may need?
Yeah, that's a great question. And as a family physician, primary care physician, I can say that unless patients bring that up, we will probably not bring it up, because it's not like really in our mindset when we're undergoing the usual the clinical sessions, the outpatient medicine that we're doing. We're kind of focused on what's going now. Is the patient doing better? Is the patient doing worse? Are the medications we're doing providing good or not? Now we may consider, is there something else that we can do for this patient when the typical medications that we provide are not working? And we're trying to think of, okay, what else is available? But until we get to the point, that is we, meaning physicians, we may not think of a clinical trial participation. So if a patient wants to be involved sooner than that point, it's important to bring it up. And there's no 100% way to, the best way to bring it up, but just bring it up. Like, is there like a clinical trial that, that helps, patients like me? Just bring it up, something like that. Just put it in the awareness of the physician, I think is going to be important. Now, that's not a guarantee to say that your doctor will actually look into what's available, but it's not going to happen unless you bring it up. And often, the primary care doctors are doing it because they want to help patients. So if they feel that that's potentially something that can be helpful, I have faith that they will look into it for you.
But then that means that the consumer or the patient has to be an informed consumer, has to do their own research, so to speak, and increase their own level of knowledge and understanding of clinical trials before they could even bring it up with the doctor, to be able to understand what the response is all about, or what maybe.
Absolutely. We may have more knowledge about a particular disease, but as far as the experience from the disease, patients are the experts. How the disease or the condition are affecting them. How did it affect your work, your social life, your relationship with family, and so on. I mean, patients, you're the experts, and so that's where you can we call this shared decision making. We can you can bring what's only available to you that the doctor doesn't know, bring it up and lay it on the table and discuss those issues. And I think that could be helpful for the doctors to understand you better, and then try to figure out what we can do to make things better.
Very good. Any other final thought about barriers and strategies to recruit racial and ethnic minority and women in clinical research? in addition to those
yeah.
that you mentioned?
I think too, and someone put this in the question about sharing results. I also think we do a horrible job as researchers of sharing our results of what we found. You know, people participate in our studies, and you know, we recruit them, we engage them, we enroll them, then we write our papers, we do our talks, and they don't hear anything back from us. I remember specifically when we did the prostate health index study with Project Brotherhood and with Dr. Murphy, we actually went back to the communities where we recruited from. We actually had report out sessions at Trinity United Church of Christ, at the Carruthers Center on the south side of Chicago, going back to the places where we engaged them to actually tell those men what we found out from that study. And I even remember sending email to the men and the citizen scientists saying, because of you, we now know that we need more African-American men enrolled in clinical trials. And we have to break this down in lay language too. We can't have the language so high that you need a thesaurus or a dictionary to understand what we're talking about. There's a way you can write this in scientific terms that the everyday person can understand. But we got to talk about the results that we're getting and the positive impact that clinical trials can have on this. And so we have to do a better job of that. And you said it before, Ida, we have to be an informed consumer. Our primary care doctors, particularly in our FQHC, they are swamped. They often have 15 minutes to address 30 things. And to expect them to have more time to talk about clinical trials is kind of unrealistic sometimes. So we have to think about how can we make the consumer more educated so that they can also know to ask those questions.
We only have like a minute or so. Any further thought about how can we overcome the mistrust that people have of clinical trials? Maybe, you know, and having more members of the research team that represent the community. Maybe one aspect that they know how to reach out and be able to communicate the importance of the clinical trials.
And I think also buying from the community doctors, you know, because not all physicians are trusting of clinical trials either. So I think, and I hopefully the patients do trust their doctors, and I think to get a buy-in from the healthcare professionals who are part of the community, you know, who are engaged in these first line medical management of the patient, I think that's going to be really important as well.
Wonderful. And there are a couple of suggestions in the chat about language that is crucial and health literacy that is also key. So I guess we are 12:59. We only have less than a minute. So I have no words to thank all of you, the participants, for listening to this webinar. Please don't forget to answer the post survey, and to thank our expert and speakers today for their wonderful work. I think we covered a lot of ground. I think it was a very, very informative and very interesting webinar. So thank you so much, Dr. Gimbel and Dr. Waxon, for your participation and wonderful words of wisdom. God bless. Bye.
Thank you. Thank you so much.